All right, so who can answer what that is up there? Any ideas?
It's a Ferris wheel.
Ferris wheel. Nicely done. Ferris wheel. It has nothing to do with liver diseases, but that one, my kid did not come up with that one. If my kid came up with that one, I would be extremely impressed.
I knew where you came from.
It's good, huh? Oh, you saw this the other night.
I forgot about it and then brought it back when I saw
That's
it.
right. This is a nice nerd joke. Ferris wheel. All right. So, in the remaining time, I want to go over some liver diseases. We need to do an overview of the liver, just like what we do with every system. But I'm going to do the overview kind of in maybe just a couple of slides. And the first one is going to be in the form of a review question. So, which of these is not a function of the liver? Protein manufacture, lipid storage, detoxification, glycogen storage, biomanufacture, or all of these are functions, all but B are functions. What's the correct answer? All of these are functions of the liver. Okay, so the liver is an extremely versatile organ. Very, very important, right? And if we look at liver physiology and we look at liver anatomy, we can kind of appreciate how it's organized. We've got the three different zones. This is a lobule. And the architecture facilitates its functionality very, very similar to the way the kidney is organized. Okay, so there's an architecture in the liver that allows for filtration to take place, much like what we see within the kidney. Now, a couple of terminologies that I want to define. So bilirubin. You guys know what this terminology is, bilirubin? So bilirubin is a yellowish breakdown product of heme catabolism. Okay, heme catabolism. So heme is found in hemoglobin, and within the hemoglobin molecule there is actually an iron molecule, which is maybe why I thought it was a joke. And oxygen binds to that iron molecule. Remember, there's 4 iron molecules in the heme group, and so the capacity of one hemoglobin is to bind 4 oxygen molecules. And as heme breaks down because it recycles, as it breaks down, you get bilirubin as a form. Now, jaundice is a condition. Jaundice is a condition of yellowish eyes, or the whites of the eyes turn a little yellow. The skin might turn a little bit yellowish, and this is due to an accumulation of bilirubin in the bloodstream. And the reason that that's happening is because the liver function may not be appropriate in order to help recycle or to rid the bilirubin. So jaundice is a coloration, but it's also a condition that takes place in patients that are suffering from a dysfunctional liver. So it happens in 2 main categories. Number 1 is it happens in premature infants, jaundice. And the reason it occurs in premature infants is because if they are born too early, liver function may not be completely operational, and so the recycling of the red blood cells is not taking place, or the recycling of the heme part of the red blood cells. And so as that builds up in the bloodstream in the infant that's premature, they become jaundice. Now, in infants, we can treat it pretty well because we can use light therapy. So we use light therapy, and that light helps to break down the heme groups and will eventually lower that enough when the liver comes online, it can actually clear up or cure the jaundice. Now, the other patient population isn't as much of a positive outcome. These are chronic alcoholics. In chronic alcoholics, because the liver is being destroyed, the light therapy won't work because it might work temporarily, but the liver's not going to come back. Okay, so alcoholics where the liver is being lost will also suffer from jaundice. Cholestasis is when we have visible biliary pigment in the cannuliculi and the hepatocytes due to a decrease of bile flow. So if the bile can't flow, it won't move from the liver into the duodenum, or the small intestine. Cholestasis. Portal hypertension. Portal hypertension occurs when we get excessive collagen deposition in the liver. It disrupts the architecture of the liver vascular system, and this occurs when there's high blood pressure in the portal vein. Portal hypertension. Coagulopathy. This is, the liver itself is responsible for synthesizing a lot of the coagulation factors. In fact, all of them, except for factor 8. So coagulopathy, or a problem with manufacturing coagulation proteins, is when the liver's not making these clotting proteins, and you get sort of abnormal blood clotting disorders, coagulopathy. Hypoalbuminemia, that's a mouthful. Try that. Hypoalbuminemia. Okay? Hypoalbuminemia. This is low levels, hypo means under, low levels of albumin in the blood serum. So albumin is manufactured by the liver. Albumin is a very, very large protein, and the purpose, this is important for you to understand, what's the purpose of albumin? Do you guys remember this from 202, from circulation?
Isn't it to keep water inside the arteries and veins?
Perfect. It's to keep water or fluid in the vascular system. So albumin is actually responsible for establishing your colloid osmotic pressure. And albumin levels in the venous circulation encourage fluid from the tissue to move into the venous circulation, because fluid, water wants to follow solutes, and because protein is a monster solute, it's going to encourage reabsorption of fluid. Okay? So if you have a patient that has a compromised liver and they're not making albumin, and albumin levels in the bloodstream crash, what do you think is going to happen to the blood volume? The fluid is supposed to be in the bloodstream. Where is it going to be? It's going to be everywhere else. It's going to be in the tissue. The patient will be suffering from tissue edema. And we'll see some examples of that here very classically in a couple of slides. Okay? So the liver is responsible for a ton of different things. A ton of different things. Which organs connect to the liver via veins? Small intestine, stomach, esophagus, spleen, all but C, all of these. All of them connect via veins. Remember, the liver, or the hepatic circulation, is all venous oriented. It's super, super important. Okay? That's also why it's very susceptible to hypertension, because the pressure on the venous circulation is typically very low. So, ascites, what is it? How does it happen? Okay, there might have been a question on the pre-quiz about ascites, was there? Okay, perfect. Maybe not all of you got it, so you're like, well, there's like a test bank, so if you don't get that one, you're still special, okay? Don't worry, it's not like I, only gave it to some of you. It's random, it's just a test bank. They're all questions that I make, but, they recycle. Okay, so ascites, and how does it happen? So if you've got a patient that's wrestling with portal hypertension, this can lead to some severe problems. So ascites is the accumulation of fluid that takes place in the peritoneal cavity. And it's a result, or can be caused by portal hypertension. The fluid accumulates between the visceral and parietal layers, and you'll inevitably get distension of veins as a result of it, because now the veins are pressurized. And the distension of veins is a term known as varices. Okay, so ascites is the accumulation of fluid, and it's in the cavity space as a result of portal hypertension that's taking place. cirrhosis because the liver is not operating correctly. If it's not operating correctly, you get low levels of protein, right? You get hypoalbuminemia. The fluid leaves the circulation, okay? It primarily leaves the arterial circulation, goes into the peritoneal cavity as tissue edema. As it comes into the venous circulation is under high pressure. And so now you get sort of these distended veins that take place. Now, why do I have this recall hypotension? If you have this state, then you release renin. Okay? So hypotension, essentially or effectively, if you have portal hypertension, then you have hypotension everywhere else. Because you're losing all this fluid. It's trapped in the liver circulation. And if you lose all this fluid, then your body thinks that it's hypotensive. And so it'll release renin, have activity at the level of the kidneys, conserve water, and increase blood pressure. Now, how do you think that is going to feed back to your primary portal hypertension problem? Is it going to make it better, or is it going to make it worse? It's going to make it worse. Okay, so these patients are kind of stuck in this terrible cycle. And this is a picture of a patient. It's an old picture, and you know it's old because it's black and white. No, I'm just kidding. It says 1981 down here. So this older picture, but it's very, very relevant. So you can kind of see two conditions that are taking place here. One is we've got this ascites. We've got all of this fluid in the peritoneal cavity. Okay, this is a chronic alcoholic that his liver is dying. And the second condition is what? What's the other one you can see? What's that? Okay, so the other one that you're seeing is the distension of the veins, right? So the varices, or the distension of the veins, is what you're seeing. So you've got ascites and varices in this one picture. Now, there's an unfortunate other population of patients that resemble this condition, okay? And I don't know if you guys are like me, but when I was younger, like 41, not that long ago, actually, until I started really diving into pathology. But when I was a little kid, I remember hearing about starving kids, okay, in other countries, right? Especially around this time of the year. Because, we're supposed to be very thankful, we're going to have so much food, we're going to, overeat, we're going to go into food coma, and, that's what parents always tell their kids that won't eat their food is, there's starving kids around the country, you should eat this food. Okay, so these pictures of these kids that we see, that I saw when I was younger, look like this. So what does the chronic alcoholic laying on the bed, and what do these young, starving children have in common? What's going on there? Yeah.
Like malnutrition? Or like
So it is malnutrition. So keep going with that. Malnutrition, so what's happening?
alcohol is basically anti-carbs and really nutrition.
Okay, so the alcoholic has empty carbs. Okay. Lost liver function. The young children are malnourished. Not enough protein in their diet. Okay. So what's going on? Yeah. The liver isn't able to function in these young kids. Won't make the albumin necessary. So they have a very similar result from a totally different mechanism. This disease is actually referred to as Kwashiorkor disease. Kwashiorkor. Kwashiorkor. It's a form of malnutrition. That was exactly correct in the back. There's not enough protein in the diet. The liver itself is starving, isn't able to manufacture the appropriate albumin. So they get a change in skin pigment, a decrease in muscle mass, they develop diarrhea, failure to gain weight, but they look like they're fat, is what I remember thinking when I was a kid. Like, how are these kids starving? They have these big old bellies. Well, the problem problem is this is all fluid. Okay? So they don't do a great job of explaining that. But now you can. Now you can explain this is a severe sign of malnutrition. Okay? The kids have ascites, right? They absolutely have, you'll see evidence of ascites, and you'll see evidence of, in some cases, the varices or the distended veins. But you definitely have the ascites. That's the same exact clinical scenario that you have in both of these patient populations. Yeah.
So is this reversible just with a healthy diet? Or
This,
like a sugar-
yeah, in the young kid it is. Yeah, as long as the liver isn't gone. Okay? If the malnutrition is so bad, I mean, these kids are almost, their bodies are almost cannibalizing themselves. Because if you don't have enough sugar and you don't have enough fat, then you'll move to amino acid fuel, right? You'll move into a protein fuel source. And that's where those young boys are, is in this, they're burning protein now, their own protein, out of their muscle mass. So they get muscle wasting because they're burning all of their muscle energy to stay alive. And then the liver can't keep up because it takes a lot of energy to manufacture albumin. Okay?
That'd be the same as ketosis?
What's that?
That's the same as ketosis?
Ketosis, yeah, so they'll be in a state of ketosis. Okay, so it's tough to see those pictures, especially now if you know exactly what's going on. But I remember thinking always when I was a kid, like, it didn't make sense. If they were so hungry, why do they look fat? You know, I mean, just being blunt, I remember thinking that in my head. Like, they look kind of like they eat too much. I don't know why they're telling us that they're starving. You know, it's kind of weird. But those pamphlets and those speakers don't really tell you the physiology behind it. Now you guys can explain that. Okay, so I want to zone in. We don't have, like all units, we only covered 3 things really in kidney diseases, and we're really only going to cover one main one in liver, and that's going to be chronic liver disease. Okay, now I've touched about some other things, that are a little bit more global impacts like starvation, things that happen in patients that even, there are patients that will develop the ascites and the varices due to liver cancer. Okay, so if the liver is infected with cancer and it won't produce the appropriate albumin, then you're going to get all these same symptoms. Okay, so I'm picking and choosing because we only have a limited number of time, but you can kind of use the little vignettes as you move on in your studies to try to remember what it was that we talked about. So I want to hone in the remaining time on alcoholic liver disease. So if we look at alcoholic liver disease, this is a summary table that we're going to start this segment of the lecture with, and we're going to end. Okay? And it talks a lot about all the different stages, and it does a really nice job of summarizing. So this is a constant flux, okay, that takes place in these patients. So what I mean by that is we've got normal liver up here. We have some sort of exposure or damage that's taking place. And in this part of the lecture, it's in the format of alcohol. So we've got an exposure of alcohol, and then you get morphological changes that take place known as steatosis. If you remove the exposure, then it goes back to normal liver. And you can also have severe exposure that move more into a hepatitis condition, and we'll talk about the differences. And then you reduce or eliminate the exposure, it goes back to normal liver. In some cases, you can see that steatosis and continued severe exposure may move on to hepatitis. There is a dotted line that if you remove it, it might go back, but it's dotted because it's iffy if you're going to be able to recover it. And then either a steatotic or a hepatic or hepatitis situation with repeated exposure or repeated pathologies ultimately will lead to a cirrhotic liver. You can see there are no arrows moving away from cirrhosis. So once it becomes cirrhotic, there is no going back. That is the point of no return. Okay? And in any given period in an individual's life or a patient's life, there may be some sort of motion taking place back and forth between these 3 conditions. Okay? Once it gets into the area of cirrhosis, there is no rescue, there is no, going back, if you will. Generally speaking, they're overlapping, but if we were going to be called out and we had to rank order them, we would say that steatosis is probably the first stage. Then more progressive would be hepatitis. And then the worst case scenario, or the most aggressive, would be cirrhotic liver disease. Okay? So what are the risk factors? Well, genetics plays a huge component. Genetics plays an absolutely huge component. What does that mean? Well, the functionality, our liver function, is not just determined by the size of our liver, but it's determined essentially by our genetic makeup and how those hepatocytes detoxify certain agents. Okay, we'll talk about the detoxification pathway specifically for alcohol here in a second. So genetics is a big deal. And then environment, like risky use. So risky use, what does that mean? Well, that's a super variable terminology. So the National Institutes of Health, okay, the National Institutes of Health have published a guide, all right, and I'll try to find this link. I couldn't find it this afternoon, but I know I can. So I'll find this link and I'll post it for you guys to look at, because this is a newer publication than even just this. So this one says, greater than 4 drinks per occasion on a regular basis is considered risky use. Okay? Well, define occasion, Rob. Define regular basis, right? So there's a lot of flexibility in this terminology. It kind of depends. It's very individual specific. You have friends, that there are certain friends that, can have like 1 drink or 2 drinks and probably shouldn't be doing anything. Okay? Definitely not operating heavy machinery or farm equipment. Okay? That's what the bottles say sometimes with the pills. Don't operate heavy machinery or farm equipment. There must be a lot of farmers that use those pills. But anyways, then you have other friends that they can have a few drinks and they're fine, or they seem fine. Okay? Now, liver size generally goes along with height and weight. So larger individuals are going to have larger livers. So usually men's livers are larger than females' livers, and liver function is usually determined by mass. But the National Institutes of Health have produced this publication. So here it is. It's in order to minimize your risk of developing long-term alcohol dependence or long-term liver issues, they recommend the following. It's 2 drinks per day, no more than 2 drinks per day, or no more than 4 drinks in any one sitting, or no more than 14 drinks in a week. Okay, so if you had 2 glasses of wine with dinner every day of the week, they would say that that's not really a big deal. Or if you said, you know what, I'm at a tailgate with my friends on Saturday, I'll probably have 4 beers, then you have 4 beers. But if you had 4 beers there, you'd only have 10 throughout the rest of the day, rest of the week, excuse me. Oops. A little bit of a Freudian slip. Okay, so 4, right? 4 at the tailgate, but then the other 6 days of the week, you were limiting it to 10. And you couldn't have 2 per day if you were going to build up to 4 on your tailgate at the football game. Does that make sense? So what their publication is if you're monitoring what you're drinking and you stay out of this sort of risky activity, then you probably won't develop dependency, and you probably won't develop issues associated with your liver. Well, if you don't explain it, you say 2, 4, and 14, most people are like, gosh, that seems like a lot. But when you play it out like that, you're really saying that at any one event, you're not going to have more than 4 drinks. And then another day of that week, you're going to have nothing. Right? And then the rest of the week, you might have 2 per day. So it's not saying abstinence, NIH. This is NIH's guideline, National Institutes of Health. Okay, hang on. So another way to look at this is, if you enjoy a social event and you're not hungover the next day, you're probably not crossing that line. But if you have a hangover, that's your body's way of saying you probably had too much to drink. right? I think most people would agree with that, okay? If bright lights, loud noises, food, or you want a beer, the next evening, absolutely not. You probably overdid it the night before. So the etiology that this looks like is excess alcohol consumption can cause damage to the architecture of the liver. So to the microtubules, to the mitochondria, as well as to the membrane fluidity of the liver. There was a question over here. You wanted me to define a drink now, didn't you?
Well, yeah, shots, drink.
Was that really what your question was?
Yeah.
Wow, I'm pretty good.
Shots.
So usually it's defined as, like a pour a glass of wine, or a 12-ounce beer, or a single shot of a hard spirit would be considered a drink. So if you had a double, that would be 2, right? Okay. All right. So what's happening? What's happening at the level of the liver? Right. Well, we've got first stage is what we call steatosis. Steatosis refers to large, soft, yellow, greasy deposits in the liver. Right? We have a condition of cholestasis, where the bile cannot flow from the liver to the duodenum. Sometimes we'll actually see some perivenual fibrosis, some little bit of scarring around the veins of the liver. In alcoholic hepatitis, we see hepatocytes starting to swell. So the liver cells, the hepatocyte, it will enlarge. And we start developing an infusion or a population of inflammatory cells. And that leads to Mallory bodies being present. Mallory bodies are wax-like droplets of hyaline filaments that form within the hepatocyte themselves. The hepatocytes start taking on internal changes, and that's shown down here on the lower right. So this is normal liver on the left. Okay, this is alcoholic hepatitis liver, where do you see, this is a good example right here on the sort of far right edge. We've got the nucleus of the hepatocyte. This is absolutely swollen. And now you've got Mallory bodies inside, which is this pink internal stain. And you can appreciate over here, this little purple dot is the nucleus. And so this is swollen with wax-like deposits of hyaline filaments within the cytoplasm of the cell. That's the Mallory body. And then lastly, most aggressively, is cirrhotic liver. Cirrhotic liver, we get micronodules. The liver itself becomes shrunken. We get sort of a non-fatty change that takes place, and we get scarring. So we're going to go over some of these things here momentarily. So if we look at the pathogenesis of the first stage, steatosis. So this is our alcohol consumption reaction, right? So we've got ETOH, alcohol, in the presence of NAD+, leads to acetaldehyde NADH, which leads to acetate. This is how you detoxify alcohol, right? So I mean, when you consume alcohol, alcohol is a poison. You call it what it is. It's a poison, and your body breaks down the poison. And if you break it down, how does it break down? The liver does that. If you break it down as quickly as you ingest it, then it's not nearly as fun as if you break it down slower than you consume it, right? So you consume the poison faster than your liver metabolizes it, and that's when you feel the buzz. But what you're doing is you're playing with poison, okay? So the poison in the form of alcohol has an intermediate acetaldehyde and NADH. Now, acetaldehyde is a hepatotoxin. It kills liver cells. It literally kills them. And so you don't want to leave it in the acetaldehyde stage too long, because that's actually what destroys your hepatocytes. So if we look at this reaction, We've got alcohol dehydrogenase, which is the catalyst that moves this from left to right. The intermediates, like NADH, this is one of the intermediates. I'll talk about acetaldehyde here in another slide. But NADH blocks lipolysis and it encourages lipogenesis. So it prevents you from using fat as a fuel, and it encourages fat storage. Okay? So alcohol consumption will stimulate a morphology change in the individual over time. Right? So if you're very, very athletically inclined or very interested in your physique, alcohol is definitely not a performance-enhancing toxin. Right? It's actually quite the opposite. It actually has the effect of turning your liver. So here's normal liver, and this is fatty liver disease. Why fatty liver disease? Well, you see all of these open vacuoles that are storing fat now because NADH blocks the breakdown of fat in the form of fuel, and it encourages the storage of new fat, including in the liver. And so you get steatotic fatty liver. Make sense? So, alcohol abuse is greatest amongst which age group in our country? This is the United States. 15 to 17-year-olds, 18 to 29, 30 to 54, or 55 years old. So it's kind of a no-brainer, 18 to 29. Right? Probably the target range of this audience for the most part. Right? So let's look at the next stage of alcoholic hepatitis. So fatty liver disease, this is actually reversible. Right? If you take away the NADH, you eliminate or you decrease the burden of NADH, you will actually move this in the opposite direction and encourage regeneration of normal-looking hepatic tissue. But what we're up against is a situation now where we're going to have continued exposure instead of abstinence. And this continued exposure is going to be in the form of alcohol. And that intermediate acetaldehyde I told you before leads to necrosis of liver tissue. It's a hepatotoxin. If you have a necrotic response, you're going to stimulate inflammation. We saw inflammation in the kidneys under the disease state. We're going to see it again here in the liver. White blood cells show up, right? Neutrophils first, monocytes next, tissue macrophages third. TNF-alpha from specialized tissue macrophages in the liver, Kupffer cells. This TNF-alpha that's manufactured by these tissue cells that are macrophage specific in the liver actually start causing hepatocyte damage. Okay? So here you can see a normal liver on the left picture. This is a Kupffer cell, this green one. It's just basically a liver tissue macrophage. That's what it is. So it becomes activated in a fibrotic response. Not only does that take place, but here's our stellate cell. These stellate cells get activated and they start laying down all sorts of matrix. These stellate cells in the liver are like fibroblasts in the skin. So when they get activated over here on the fibrotic liver, they start producing additional forms of collagen and extracellular matrices. This collagen and extracellular matrix becomes more densely organized, and you start losing the normal architecture of the liver. Now, everything that you see on this slide, including this picture up here, which I'm going to talk about in a second, is reversible except for the fibrotic deposition. So that fibrotic deposition is scarring. It's just like what we saw on the skin. Okay? And if we look at this inset in the upper right, this is sort of a classic situation of alcoholic hepatitis. And this is a higher magnification view than what we saw before. And all of the pink stain are the maillary bodies. Okay? All of the pink stain inside of the maillary bodies, inside of the hepatocyte. So you're laying down new intracellular deposition of hyaline cartilage as you sort of reorganize the hepatocyte into a non-functional status. So again, reversible up until the fibrosis. And so they're overlapping. So there's a little bit of fibrosis with alcoholic hepatitis. And as we continue the exposure, and now we move into cirrhotic liver, now we actually have fibrosis from repeat stellate stimulation, those stellate cells. We get macrophage growth factors being released, those Kupffer cells, and that actually causes hypertrophy of the liver itself. It enlarges. We get repeat cycles of alcohol damage and resulting fibrotic changes, and then we get complete rearrangement of the architecture and even the portal hypertension that ensues. Okay? So again, this is the gross appearance of the liver. Again, bumpy, like what we saw over in the kidney. And if we look histologically, you can kind of see these bumps. Like if you were to look at the surface profile, you see how this isn't smooth? It's bumpy because you have all of these regions of fibrotic scarring. So in this particular stain, this is a different type of stain. This is a pentachrome stain. All of the nodules that are fibrotic are these sort of pink structures of scarred fibrotic tissue. And this is no longer reversible, just like what we saw with the kidney. Okay? So to bookend this, back to this picture, you kind of appreciate where we just left, cirrhotic liver, bumpy. They're overlapping stages. And as the normal liver is exposed to alcohol, it might start to develop a fatty change as you block the breakdown of fat to liberate energy and you encourage lipogenesis. Reversible. You may actually see some necrosis of the hepatocytes, some inflammation, Mallory bodies being formed. Again, much of that is reversible except for any scarring that might take place. And as things continue and you start developing these hyperplastic nodules, that's what the bumps are that we saw. And internally, the fibrotic scarring. Now you're in the stage of non-reversible. Okay? So we kind of have three overlapping stages of liver disease as we finish out today's lecture. So these are the different clinical symptoms that are associated with each of the categories. So you can see enlarged liver with the first stage of steatosis. So on palpation or on imaging, the doctor might actually feel an enlarged liver. Elevated bilirubin levels, right? Because now the liver's not recycling things like it's supposed to. As we continue on to our more aggressive stage, alcoholic hepatitis, malaise is like just general bad feeling. Anorexia, inability to eat or a loss of appetite, weight loss. The liver itself becomes tender. Now you have hyperbilirubinemia, where you've got really high levels of bilirubin. Now the patient is going to start becoming jaundice. These get more aggressive in the cirrhotic liver disease. You see things like portal hypertension, the ascites, or the fluid that takes place in the peritoneal cavity, peripheral edema everywhere else, malaise, weakness, weight loss, and even more aggressive jaundice. Okay? So again, I will find that NIH publication. Genetic predisposition is a big one, but the other one is environment and how we're actually, enjoying our lifestyle. And so trying to find a safe range that's not risky, that's not overdone, I think is important to establish those healthy lifestyles for the long haul. I'm not saying abstinence and don't drink at all. I'm just saying try to set these healthy habits early on. And the NIH guideline, I think, is actually pretty helpful. Okay? Any questions? Kidney lecture or liver lecture? Any questions? Okay. Have a great Thanksgiving. I'll see you next Monday. Don't forget your post-quiz on Friday. Maybe take it before you leave town. Okay? Take care, everybody.